My name is Lolly Gardner, and I'll be the moderator for this session. We have three guests with us, Dr. Balin, Ms. Coburn, and Dr. Earhart. We'll start with Dr. Earhart, who will give us an introduction to testing and surveillance and talk about some of the work that she's been doing during SARS-CoV-2. Then we'll move to Dr. Balin and Ms. Coburn, who will talk about contact tracing. So I'll just start real quick with a couple bios so we know who we're talking to here. Dr. Earhart is the director of the Colorado State University's Columbine Health System Center for Healthy Aging. She's also a full professor in clinical sciences at the College of Veterinary Medicine and Biomedical Sciences at Colorado State University. She holds the Ross M. Wilkins, MD, Limb Preservation Foundation University Chair, mouthful, in musculoskeletal biology and oncology. He is the director of the Laboratory of Comparative Musculoskeletal Oncology and Traumatology and has been involved in limb preservation research, regenerative medicine, tissue engineering, cancer research, and she's been doing this for the last 20 years. She's actively engaged in transitional aging research to improve health and the lifespan for aging patients, both human and canine. She focuses on comparative medicine as a powerful tool to bring new therapeutic strategies to slow aging. She holds a joint faculty position in Colorado State University's School of Biomedical Engineering Cell Molecular Biology program and the University of Colorado Gates Regenerative Medicine Center and the University of Colorado Cancer Center. In addition to her leadership roles in many prestigious and national and international scientific organizations, Dr. Earhart was also the first woman to be granted the university-level endowed chair at Colorado State University. Welcome, Nicole. Dr. Balin, I don't know if her picture's up there. Dr. Balin has served with the NIH Occupational Medical Surveillance for over a decade. She is currently its acting medical director. Previously, she worked in primary care and emergency medicine in Maryland, the District of Columbia, and Wyoming. After earning an MD at the University of Maryland, she completed a surgical internship and a family medical residency. She embraces the practice of occupational medicine as a public health in the workplace. Dedication to learning and compassion drive her commitment to provide medical support tailored to the needs of the workforce she serves. She enjoys anticipating concerns and developing systems-oriented solutions to alleviate them. For example, a monitoring program for Ebola response workers or the current employer-based pandemic response for the workforce. Then we have Ms. Cody Coburn, who is a registered nurse. She's the Occupational Health Division Director for CU Anschutz Medical Campus Department of Environmental Health and Safety and oversees one of the first university-based contact tracing programs in the state of Colorado. Prior to working for CU Anschutz, Cody worked in critical care environments for 12+ years while going to school full-time. Currently, Cody is not only the Occupational Health Division Manager, but she is also pursuing her master's in leadership from Grand Canyon University. So thank you all for being here. That was a mouthful. You guys have so many things going on in your life. I'm so excited to hear you talk about what your passion is, and we'll start off with Nicole. I think you're on mute.
Get off me.
Okay,
Wonderful.
Thank you.
Lolly, thank you so much for that kind introduction, and hello, everybody. It's a real honor to be presenting today, and I'm so honored to also be on the panel with these other distinguished panel members. So look forward to the discussion that we begin. So the work that I wanted to share today is, like many people who have pivoted some of the existing work that they've been doing to respond to the COVID pandemic. This is one of those examples at CSU where we've been doing longitudinal surveillance testing in skilled nursing facilities among workers to better understand how the SARS-CoV-2 virus is transmitted and has been causing so many significant mortality issues. So to give you a very brief kind of evolution of how this occurred, I want to bring you back to mid-March, maybe early March even. This was prior to the first confirmed Colorado case. And many of us were observing this pandemic begin to unfold, and we had a lot of issues that were of high concern. And as we began to talk amongst ourselves, we realized that there was a lot of coherence. And so we all understood the potential emerging threat to older adults, especially those in residential community care. We knew that at the time there was extreme shortage in testing availability, that the early CDC PCR tests had contamination issues, and that really had put the United States far behind the 8 ball in terms of response. The state labs were moving very slowly, and testing at that time was limited to only hospitalized patients. And all the testing was directed at diagnostics, but there really was not any discussion of surveillance and how that might impact or help mitigate potential outbreaks. So many of us recognize that there were, because we have such a large BSL-3 footprint at CSU, that the research labs at CSU represented an untapped resource for special population surveillance testing in Colorado, and that we could scale up and operationalize this fairly quickly and inexpensively. And then I was the new director for the Center for Healthy Aging at CSU, and I had already been establishing relationships in skilled nursing facilities for aging research. And then my colleague, who's the co-PI on this, Greg Ebel, had considerable expertise in surveillance, and he was willing to pivot his activities. So it was kind of one of these, perfect storms in a good way that we were able to respond. So then, here in early March, we had the first COVID-2 reported in Colorado. And at that time, there was a policy handed down by the governor that senior living communities needed to discontinue visitors. And the CDC guidance at the time for these types of facilities was to screen all workers there for symptoms and to take a history of any potential exposure. And the idea there was that they would be able to identify potential vectors. And the symptoms were things like fever and cough, which we have, recognized there's a far greater spectrum of symptoms. But at the time, that was kind of the big, red flags that they were looking for. And we also were sort of aware that there was very little discussion among the public health authorities about the pre-symptomatic or asymptomatic phases of this particular disease. And as a result of that, we were concerned that asymptomatic or pre-symptomatic people, specifically workers who had to come and go every day, would be vectors for silent transmission. And these people were very vulnerable, and it was sort of a spark in the driest, tinderwood that we were concerned would set off this, raging forest fire. And we knew that symptom screening is not going to pick up asymptomatic or pre-symptomatic people. And so bring us now forward, and I have updated even information from now, but the statistics really haven't changed, is that if you look at all the deaths in Colorado, confirmed deaths in Colorado, over 50%, so 56.4% of all deaths in skilled nursing, or in Colorado, or in skilled nursing facilities, are senior residential care communities. So this is an enormous problem, and it's caused, obviously, tremendous suffering for many families. So the project that we did is we recruited 600 workers that consented to have us nasopharyngeal swab weekly for 8 weeks. And we had 6 total facilities that were part of the pilot program. The entry criteria to be part of the study was that they had no reported COVID-19 symptoms, no known exposure, and they had to consent for us to stick that nasal swab up their nose for 8 weeks, which in retrospect, I think was really very generous of them. And if they became PCR positive, they agreed to self-isolate and then continue to be part of the testing cohort where they'd be tested weekly. And we actually, if we got positives, we confirmed them by 2 independent labs and reported them to public health officials, as we were mandated to do by law. So to give you kind of the Reader's Digest version here, what was like very, very concerning was that 15% of the initial 542 enrolled workers were positive. These were people that had no idea they were positive. They were reporting for work every day. They were symptom screening just as they were recommended to do, which was really sobering. Furthermore, what was really interesting is that this was asymmetrically distributed across different facilities. So in some facilities, we had a very low amount of asymptomatic positives. In others, we had a very high number. And then when we looked at the job codes of those people, you would think that people that had direct patient care would be the most likely, given that we were only testing workers, and perhaps the workers were being exposed by residents that they were caring for. So therefore, nursing and other therapy hands-on people would potentially have the highest transmission rate or positivity rate. And in terms of that, that was true in the sense that nursing did have a high rate. But look at this, there are others. So this is like maintenance, admin, others, a very large proportion. In fact, maintenance was one of our largest ones that had the highest percentage, even higher than nursing. So that was another real sobering conclusion, that this was not something that was just limited to people with patient care. We were also at the time wondering whether just because you were pre-symptomatic, did it really mean you were infectious? And in fact, we were able to confirm that using plaque assays. So these are just graphs showing the CT number for the N1 primer set for the virus, and showed that we were able to not only have, so we had 3 different primers, but then if you look at panel B, what you can see there is plaque-forming units per swab on the y-axis versus the N1 copies per swab, and you can see a pretty linear association there. So these people were, in fact, quite infectious, especially, here at the top end. And so we kind of quickly put to bed the idea that was kind of circulating at the time that these people really may not be infectious to others, despite the fact that they were positive, and just because they were asymptomatic did not mean that they were not infectious. So we completed an 8-week study, and in this illustration here, the green triangle is the prevalence of positive workers at the first week of surveillance, and the incidence of new cases are depicted by the blue circles. So you can see there was a pretty wide distribution. So here's site A, which really pretty much was very quiet, but look at poor site D. We found, 23-ish% workers were positive at the time. And what was really fascinating to us is when we identified those people early and took them out of the workforce, we were actually able to mitigate new infections over time. Occasionally, you'd see these sort of bubbling little infections that would come up. But again, the whole point was to find these people early and isolate them away from others in the workplace to prevent new prevalence or new cases. This is the phylogenetic tree of all of the genomes. We did deep gene sequencing for all of these. And you can see that, the color represents facility. And what's immediately striking here is that the facilities did cluster among themselves, and they were quite close. So this suggests that instead of having like very many import events, which was kind of our first hypothesis, is, workers are going to Home Depot and somehow getting exposed, and then different workers are coming in with their different viruses from the community. What we found, in fact, was that viruses being transmitted from worker to worker within facility much more commonly than there was new import events. And so that was another very important finding, because it does suggest some interesting mitigation strategies. This is how our phylogenetics fit into the overall phylogenetic tree depicting the evolutionary relationships of the SARS-CoV-2 genomes. Ours are in the mint green up here. So you can see we've been very committed to open access sharing of these data and these genomes to sort of help with the overall epidemiologic and phylogenetic tracing effort. Interestingly, too, we were able to draw blood on a lot of our positive workers. And what we found, and this is just raw data that I'm presenting here, so I apologize for not having it in graph form, but this is really very new data, was that if they did not have neutralizing antibodies, generally that was associated with a low RNA copy number. But there were some people that when we first drew their blood after their first PCR test, their neutralizing antibodies were low, but then they seroconverted. And then the next kind of interesting piece from this data was that serum that was drawn at least 2 months out from their first infection still had neutralizing antibodies. And often this second blood draw was 4 months after their known infection. So we've been hearing about antibodies waning over time. And in fact, at least in this cohort, it seems that these people continue to have neutralizing antibodies for long periods of time. This is just in one facility, remember I showed you the facility that had no infection over the 8-week period, and we were surveying for their antibody presence for 2 different antigens, in this case, receptor binding domain and the spike protein. And you can see a high number of people that had seroconverted. So about 40% of people at the time we started testing actually were positive on antibodies, but never had infection. So this is also suggestive, and again, this is brand new data and really early, but potentially of that kind of herd immunity concept. And so we were pretty excited about this and continuing to analyze that. So the conclusions here is that screening for COVID-19 symptoms are not sufficient to identify positive workers, that asymptomatic and pre-symptomatic positive people do have high virus loads and they are infectious to others, that transmission occurs most commonly within facility rather than by separate import events, and that early identification and isolation of positive workers was an effective strategy to mitigate new infection over time. And certainly that serial surveillance serves as an early warning and mitigation strategy to combat future outbreaks in nursing home facilities and other residential care communities. And certainly one-time testing is not going to be sufficient to detect early outbreaks. So I will stop sharing there. And, oh, I do want to share, sorry, that we do have some ongoing studies. We've been funded by the state of Colorado to expand our cohort. We now have, as of last Friday, 20,000 samples. What's kind of interesting about this cohort is that it differs in our, during a time where there's different control recommendations, right? So now visitation is opened up to outdoor visitation, restaurants, et cetera. So this will be a very interesting cohort to compare temporally to the prior cohort, which was collected during the most, strictest lockdown phase. And we're continuing to assess antibodies and sequencing the genomes of these viruses. We've also been doing survey collection to assess symptoms and demographics, and we're going to be doing a pretty intensive host genomic response study, so looking at genomic expression in respiratory epithelial cells that are collected along with the swab to see if we can see any differences between people who eventually do get sick from the disease versus those who seem to remain asymptomatic or mildly symptomatic. So I will pause there. Yes. Does somebody have a question?
I don't see any questions coming in, but I'm not quite sure on how the questions happen over here. So if there's a question that came in, Cindy, let me know. Otherwise, we will move to Dr. Balin and then open up the, at the end of the hour, at the half hour to discussion. Okay, we'll move on to Dr. Balin then. Segue into contact tracing.
Okay, let me see if I can pass my IQ test here today. And okay. So thank you for the opportunity to speak today and to participate in this roundtable. I think it's a very current and very concerning topic, contact investigations, and I really appreciated the talk that Dr. Earhart just gave and including the data. So I'm slightly envious because I don't have similar data, but the story echoes a lot of our experience. I'm actually making it relatively easy in having just one slide and hoping to use it as a background for the story of contact investigating activities at the NIH. As many of you know, National Institutes of Health are a conglomerate of institutes and centers, 27 of them in geographically dispersed locations, Maryland, North Carolina, and Montana, but also a smattering of people all across the United States, including Arizona. And my branch is within the Division of Occupational Health and Safety, the Occupational Medical Service, or OMS. Before all this began, did an occasional contact investigation. One of our centers is the Clinical Center, a protocol-driven research facility, clinical research facility, where we would probably have flu contact investigations, occasionally some tuberculosis, a smattering of other pathogens, but it wasn't very frequent and it was very targeted. Of course, when COVID hit or snuck up on us, we had to change our approach. And this is just like the story everywhere else. What can you do given your particular area and population to support with these activities and available resources. So what I'm talking about, big disclaimer here, is how we happen to do it right now, but it's subject to change, and it is not the way to do it. So bear that in mind when I tell you how we are currently doing it. So just briefly, a component of a contact investigation for people who are not as familiar with some of the epidemiological and clinical terms, it begins with a positive case usually. What does that mean? Someone is diagnosed with a disease that may be infectious. And I should actually say not necessarily a disease, but with a condition that may be infectious. Because like Dr. Earhart just pointed out, there's a huge concern for pre- and asymptomatic persons who are quite capable of transmitting the pathogen SARS-CoV-2 in their surroundings. So when we receive news of a diagnosed case, we start with an index case interview. And in order to be a good contact investigator, you really have to have a specific mixture of empathy and a forensics mind almost, in that you speak with a person who just found out, who may have just found out. In many cases, when we're doing the testing and resulting it, they're anxiously waiting, oh my gosh, do I have it or not? And then they hear it, they get the call the same day, and may have concerns, both for their loved ones at home, for their job, for their income, for their coworkers. So you have to have some empathy in conveying this. They may have personal health risk factors that could put them at greater risk for complications and disease. And we've seen quite the range of symptoms pretty much from the beginning, and severity of disease as well. So the second component is the assessment of contact tracing. So although it says contact investigations, it really starts with the individual and then moves on to see where else could the virus have gone at the point that we are in touch with the index case. And to me, contact tracing really is part and parcel of risk mitigation, of institutional risk management, and therefore is worth all the resources that are available to throw at it. And I should say that NIH, is lucky or fortunate that we are working in a very resource-rich environment. So unlike other employers who are struggling, other workplaces who may not have the resources to do extensive tracing in the workplace, our focus as the Occupational Medical Service for the NIH is primarily to deal with the individual notification and then to mitigate risk in the workplace. Part of that is, of course, contact tracing itself, but also environmental mitigation. Our colleagues in the Division of Occupational Health and Safety are the ones that developed quite an extensive plan to see what is feasible in each and necessary in each individual case. And how this, for example, may be handled differently than a laboratory where essential research is being conducted, and that needs to be up and running, preferably the next day. So different strategies fit for different situations. So a quick note on how do cases come to us. The majority of our over 340 cases have come to us through our own testing programs, and quite significant number also come to us by being reported as community tested persons. They may or may not be on site. We very quickly followed suit and shut down operations down to essential work. So mainly COVID and essential facilities like our power plant and of course rescue, police, security kind of efforts, and then various laboratory functions had to be maintained It's a very robust animal research portfolio that needed to continue awaiting reopening, and that went on from about mid-March, and we are just now gradually dividing our staged opening for different groups depending on the activities and portability of their work. But that's a different story. So our testing programs started off with symptomatic screening. So we followed the CDC guidelines fairly closely, and were able to use in-house testing that the clinical center developed in their Department of Laboratory Medicine. Lots of credit goes there to Dr. Frank, the head of it, who quickly validated assays with a good amount of capacity from the get-go, such that we were able to identify our first case in the first week of March after beginning testing in late February. It was symptomatic at first. It was driven by how sick are you? We had to preserve resources. So our first few cases, we were still that sort of hands-on contact investigation approach. And very quickly, as we developed more testing capacity, that was no longer feasible. We had to stand up a lot of teams and were able to ask our nursing department to help with contact tracing, trained them to still continue when a symptomatic case was identified with the typical period of infectivity determination and individual contact tracing, but we quickly had to involve management and coworkers while preserving confidentiality of the index case as much as possible to help mitigate risk in the workplace. An educational piece was frequently necessary to help engage people in the now testing, tracing, testing cycles that became necessary in some cases. Of course, people who were teleworking, no contact investigation needed. So that was part of the initial investigation interview. The infection control measures, I should go back. Currently the other branch and really larger branch in terms of volume, testing volume, is what we call the asymptomatic programs across various campuses. So this is more in line with screening or surveillance to better understand prevalence on our campuses. And we stood up in North Carolina, most recently Rocky Mountain Laboratories, and on the NIH main campus in Bethesda, Maryland, a sizable program that has permitted us to test run over 17,000 tests and testing about 6,000 individual workers. We are trying to ask people to engage in exactly what Dr. Earhart mentioned, frequent retesting to understand current prevalency rates. Positivity rates have been very low. So I think what that tells us is that we perhaps need to ask more people to engage in this kind of screening so that we can keep close tabs on the risk for people on campus, both to protect our patients, but also vulnerable animals and, of course, coworkers. We understand risk as linear, so it's more of a spectrum. But for purposes of contact tracing, when there is someone who has symptoms, we still look for contacts and put them in two bins, high risk and low risk, and then they have separate processes to help with infection spread, with control and prevention measures. So asymptomatic and high risk a contact defined as 15 minutes within 6 feet, and preferably a mask on both, but definitely the source. If you don't meet those criteria, you would be considered a low-risk contact. If one of those criteria is violated, we may put you into the high-risk bin and ask you to quarantine. And then we can use a partial test-based strategy to ensure that you have not become infected, even though you may not have symptoms, before returning you to work. An interesting piece is for about 2 months, we used a test-based return-to-work strategy. And some people cleared it as quickly as 5 days by PCR, I should say. And then others, about a dozen or so, took about 3 months to become negative, to have no detectable viral RNA in their nasal secretions, and everything in between. Since then, we, in part based on emerging data, we were able to go to a time and symptom-based strategy that allowed people to more quickly return to work. We have a return to work program that whereby we follow each index case and make sure that they understand what is required, that they understand resources, such as when they get very sick, we guide them to outside care. Although the NIH Clinical Center conducts trials for COVID treatment, you cannot just simply participate in it without referral and evaluation. But that's part of our job, to make sure that workers can have access to appropriate level of care. I should mention that our monitoring protocols were more on the spectrum before we had so many cases. Right now, we ask people to either engage in active monitoring if they're asymptomatic and high-risk exposure, and in return-to-work monitoring, where we also ask for daily symptoms check, but we're looking for improvement of disease. This too serves to tailor our approach, if need be, in more severe cases that still don't need to be hospitalized, and ensure that they can come back to work when they are ready to come back to work. Working within a system for the NIH is hugely important. We're a very diverse workforce. Both in terms of risk factors, personal risk factors, but also in terms of the type of work that you do, and susceptibility to having to work closely. So currently, we ask that everyone, or require that everyone, stays at least 2 meters apart and wears a facial covering whenever on campus, and of course, good hand hygiene. Some jobs can't strictly observe that. So again, that is something that we work with, particularly when people return to an environment where they might be shunned if they come back from a diagnosis with COVID. So that's why I have additional support systems like employee assistance program, counseling, and other support measures to ensure that everyone can return to work. Some people have exposure risks that are multiple. They could be from the community, they could be friends and family. Some people have absolutely no idea where they could have caught it. And there are some people who may have caught it at work. We have not done any genomic testing, but given that there are, in some cases, a good chance of exposure in the workplace, we support their Department of Labor processes, such as claiming a workers' compensation claim. And of course, it becomes an OSHA reportable, OSHA recordable concern when someone is likely infected in the workplace. I think I'll stop here right now and wait for the question and answer session. Thank you.
Thank you, Dr. Bailey. Cody, Ms. Coburn, would you like to talk about the program there at CU Anschutz Medical Center?
Absolutely. So let me just pull up my slides. Okay, can everybody see that?
Not yet.
Let me see. So share, application, PowerPoint.
There we go.
Yay! All right. Okay. So first and foremost, thank you all for having me here. I really, it's a very exciting topic and a very popular topic of conversation, especially recently. So I'm Cody Coburn. I am the Occupational Health Division Manager for the University of Colorado Anschutz Medical Campus and the Denver campus. For the purposes of contact tracing, we only serve the Anschutz campus, but currently they run my model, so it's very similar over on the Denver campus, just with different individuals. So to start out with, we do have a couple of different screening options for our campus. One is the QR code screening checkpoint, where all visitors to campus have to come and be screened. What you do is we have our QR code that a lot of us carry on our badges. You use your phone or camera, or there are links to the application where you submit 3 questions. These questions include, are you exhibiting symptoms? And then it lists the symptoms of COVID. Have you been in contact with a COVID positive individual? Unprotected contact with a positive individual. We have to use that discretion because we are a medical campus, and so we do have individuals who are coming back and forth from the hospital, and so you know, those physicians, they wanted to make sure that they were still able to come over to our side of the street, and so we allow that. And then we also, if you have had a COVID positive test in the last 14 days, is another one of those questions. If at any point somebody says yes to those questions, a automatic email gets generated to the individual as well as me. It goes into my inbox, and then I can follow up with that individual. And then for the individual, it gives them a email where it says, please do not come to campus, you know, contact Cody Coburn, or you will be contacted by Cody Coburn. And so a lot of times, you know, 9 times out of 10, it was a, oops, I didn't mean to press that button, but that's okay. And so we just screen those individuals out. Occasionally we do get the individual who's like, yeah, I have a headache. I was throwing up yesterday. You know, I'm just not really feeling great. And so I do have the ability to test those individuals, which we'll talk more on the other side of on the next slide. So if we do have somebody who goes through the screening checkpoint and they do get their temperature taken once they've had their questions completed, they get their temperature taken. They have a temperature above 100.4. They get a letter that says, you know, please exit the building, contact Cody Coburn in Occupational Health. If it's between 99 and 100.3, because a lot of times we do have crazy erratic weather here in Colorado, where it can go from, you know, being, you know, 100 degrees to 30 degrees within a couple of hours. So we allowed for that kind of in-between period. So a lot of times, you know, if it's really hot outside, we'll just say, hey, can you just, you know, take a minute, get some water, you know, and then we'll retake your temperature. Every single one of those individuals who we rescreen usually come back within normal range. A lot of times they're like, oh, I was just sitting in my car and it was hot, and you know, I don't have any AC in my car. or the opposite of, it's cold outside. And so we do use a couple different screening methods. If we're not getting a really good, accurate temperature on a forehead, we do use the collarbone as our secondary source, because we'll get a difference on that. Whereas we'll get a low temperature if it's cold outside. So we kind of give a little bit of leeway in that. But if they're above 100.4, we ask them to go home, and then they need to be fever-free for 24 hours before returning back, as well as most of the time, I recommend that we go ahead and send that individual for tests, just because we want to make sure that we're capturing all those individuals. So the other way that we can capture individuals through our program is through our COVID-19 self-report form, which is on our website. So if they know that they're ill or that they've had an exposure, they know that they're not supposed to come to campus, but they want to report it, obviously, because we asked for that, then they fill out the self-report form. Self-report form automatically comes to us as well, and then we have currently 4 contact tracers that we give cases out to from there. So I will talk about the testing piece. Okay, so we'll do the contact tracing piece. So the contact tracing that we have, once we have somebody who has a positive test, so say I send somebody for testing, we ask them to stay off work until they get their test results. They get their test results back and they are a confirmed case. This is when it starts to activate our contact tracing. Most of the time, we've already gathered a lot of the information beforehand and kind of have it at the ready for when they submitted a form or if they went for testing, so that we know these are the individuals that we need to contact or the people that they came into contact with. But we do not activate that until we have a positive confirmed test. So if that individual did make contact with a COVID positive individual, then they need to be quarantined for 14 days from the date of contact. So what we do is we contact the individuals that we got the information from the positive source, and say, it's better if you call the individuals rather than giving them that kind of information, because, it's kind of a not nice conversation. They're going to be surprised and they're going to be upset. And so a lot of times we want to make sure that we have that person's phone number, so we call them directly. And because all of this is completely confidential, everything that the self-report form, the QR code, my testing, everything is completely confidential. And so the only thing that we can say to those individuals if they met contact is that you have come into contact with somebody who has identified you as a close contact. They came back COVID positive, and so we need you to quarantine for 14 days of the date of contact, which was this date. And so we'll work with that individual to come up with a plan of where they need to quarantine. We get their information as far as, do you have a safe space to isolate in? Do you have a private bathroom? Do you have the availability to get groceries? Do you have access to internet? Do you have all these resources? Do you have supplies? Because we do provide those things, or can provide those things from the university. So we, if the person doesn't have a thermometer, or they don't have hand sanitizer, because those things have been hard to find, those are things that we can provide to them. And usually what we do is we get their address, and then we go and I have little, let me grab one. Oh, we have these little kits that we provide to all of our individuals who are either quarantine isolation. And in these kits, we have gloves, masks, hand sanitizer, and the thermometers. So that is something that we can provide to them, because really the goal of any isolation or quarantine period is to make it so that they can be successful in that period, and that they're not going to have to feel as though they need to go out and potentially expose people. Because not only do we want to prevent any sort of exposure on campus, we want to make sure that we're also providing resources so they don't expose others in the public. So that's always a big thing for us. So at that point, the person who was in contact would be a suspected case. So individuals who are suspected cases are quarantined for that 14 days. Now, if they become symptomatic at any point, then they move up and become a probable case. And in that point, we do recommend and can send them for testing. So the way that we have testing set currently is that we use the UCH, the University Health System, in order to, and I can generate a order through Epic in order to send those individuals. But under my protocol, they have to be symptomatic. So once they become symptomatic, then I can send them for testing. Now, they change from a suspected case to a probable case, and their definition of isolation changes. So they change from the 14-day recommendation to the 10 days of isolation from the date of symptom onset. Now, if the person does come back positive, that is when we have a outbreak. So it has, an outbreak is 2 positive cases within that are connected within a 14-day period. We at the Anschutz on campus have not had any outbreaks because most of the time we're capturing these people very quickly. We're isolating them very fast, and so there's no, and we have such strong protocols for quarantine, isolation, and then the social distance as well as the mask, that really, even when we do have somebody who came to campus and was positive, they do not meet those definitions of contact with anybody. And sometimes they haven't even been around anybody else. We also provide the same kind of service for those who are on campus as well as off campus. So if I receive a self-report form for an individual who hasn't been to campus since March, I still like to know about it because we want to provide that support to that individual and make them, you know, and nobody wants to be sick, and so we want to be able to provide that support to that individual as well as the recommendations and be able to help them with any sort of follow-up if necessary. So. So diagnostic testing. So like I said, we can run 1,000 tests per day. Currently at UCH, they're running about 600 plus tests per day through the Anschutz campus. So we do have those. Based on our current numbers, we are, you know, based on phone calls, emails, or the QR code, I am testing about 12 individuals a week. And out of, you know, all of our tests, we've had a very minimal number of positives come back, and I'll talk about that on a couple slides later. So, like I said, my program only allows for symptomatic testing. And then for the close contact testing, currently recommendations are, it is not recommended or required for individuals to be tested if you are a suspected case. And what I tell people is that, you know, and a lot of people are like, hey, you know, I would just feel better if I got tested, which is totally fine. I just can't test under that protocol. And so they would have to go to the University Health System and get tested on their own. But if they do decide to do that, I do give the recommendation to have them test 7 days post-exposure, because that's when the viral load is going to be the highest. If you're testing 2 to 3 days after exposure, the viral load is not going to be high enough for there to really capture that, you know, viral amount. And so we give the recommendation that they wait for the 7 days. And of course, that can definitely change. And it looks like under the outbreak protocol from, I get a lot of our authorities from our local public health agency. And so under the protocol for outbreak with Tri-County, they're looking at maybe starting to do, if we do have outbreak situations, doing close contact testing for individuals 7 days post-exposure. So that's currently in the works right now, but we haven't started that. The other thing that we are projected to start is that we are going to be opening up a testing site here on campus under our own health system, so under my protocols and with my equipment and my staff, which will be very interesting. So we would open up a drive-through testing site in one of the parking lots, and then we would be able to, if need be, do surveillance testing if there were that outbreak situation, or if people really want to get tested. And so we're looking into that. Now, we do have the availability of antibody testing. Antibody testing, of course, is non-diagnostic. It is just kind of giving you a picture of whether you were positive in the past 3 months or not. But it doesn't show the current infection, although people do inquire about that a lot. And so that's why we wanted to make sure that it was available. So UCH does provide that service. So based on our information from June up until just a couple days ago, we had a total of 253 cases that we did the case investigation and contact tracing for. We isolated 153 of those individuals, quarantined 72, and then cleared. Our cases, when we get them, sometimes individuals are like, my cousin's uncle's brother was positive. And so while we still talk to those cases, we do clear them right away because there was no exposure met. And then out of those cases, we did have 79 suspected, 114 probable, 32 who were confirmed, and then the 28 that were cleared in that period of time. And then through the attestation process, we have identified 15 of those individuals, and then most of the time individuals were exposed off campus. The people who were exposed on campus is 14. Number of outbreaks, like I said before, were 0, and then we have identified 2 off-campus outbreaks, one among students, and then the other one from a off-site clinic. And so while we do not trace those individuals off campus, a lot of times because they do report that information, we do work with the local public health agencies to give them that information or the pieces that we have so that they can do further investigation. So based on that, we do have our confirmed, probable, and suspected cases off by day. Of course, as you can see, we do get a lot of probable cases, and this is because we consider people who are symptomatic to be probable cases. Now, they may not stay that way because we may have individuals who, are defined as a probable case, they get tested, they're negative. And so we can release those individuals as long as they have a negative test and they are fever-free within 24 hours. The additional request that I have made recently is that they be GI symptom-free for 24 hours as well, just because we are seeing, there have been some outbreaks due to onions just recently. And so I wanted to kind of weed that out if that was, potentially an issue, as well as, we're getting more into fall and into the winter months where we're, potentially going to start seeing some stomach bugs and those viruses start to pop up. And so that's why, we want to make sure that people are really 100% before they are able to return back to work. So number of cases per week, same kind of information there. So, it really is more in the middle of the week that we tend to see those, positive cases. I wonder if it's due to the availability of testing. If people feel as though, we don't have testing available on the weekends or, they just don't think about it. But, yeah, we tend to see more of the reports come in or the results come in on Thursdays and Fridays. So this does look like a scary graph, but I will say that Our test positivity, the red spike there, is because we were just starting out on our cases. And so as you can see, our cases were and the number of tests were very low, but we did have one positive that day, which then made our positivity rate go up. But as you see that we started to test more, our positivity rate started to kind of balance out. Now this is only for the people that we test and not for the entire population. So this is only for the individuals that we send for testing through UCH. So that is the end of my presentation, and I will open it up for the questions.
Thank you so much, ladies, for those great presentations. I really appreciate the information on testing, surveillance, and contact tracing. There are a couple questions here. One, you kind of touched on it a little, but it's open for everyone. If people are sent home with 104-degree temperature, why are they allowed to return to campus when they are fever-free for 24 hours versus getting a negative COVID test?
So I can answer this. So like I said, my recommendation when I do get those 100.4 fevers is that they do get tested. And so I do wait until we get the positive or the negative test back before we make our recommendations whether they can return back. So usually the recommendation is that you have the negative test as well as the fever-free for 24 hours without the use of antipyretic medication. So like your Tylenols, your ibuprofens, and those kinds of things.
What if you've been in contact with somebody, you've been COVID positive? Do you still need to wait those 14 days, or can you have a couple negative tests within those 14 days that would allow you to go back to work or school, or you have to adhere to the 14 days?
Yeah, so currently our recommendations, you do not get released from a quarantine based on testing. We release you based on time, just because, the testing, while it is better than it has been, we want to make sure that you're not going to become positive during that 14-day period because of that exposure.
Another question, I know Dr. Earhart answered it, but I think it's good to just bring up the question and then you can give the explanation again if you don't mind. The question is, does anyone have an opinion regarding contagiousness of someone who might actually help, who has recovered, has no symptoms, but still might have detectable virus?
Yes. So we've seen that a lot as well. So people can have RT-PCR positive tests for weeks and weeks, even in some cases months after positive, from the first positive test. But we were actually wanting to answer that question. So what we did is those plaque assays on the serial samplings from those people that were positive more than 1 week. And we've had people that we've serially tested weekly for 8 to even 10 weeks. And in all of those cases where people were positive on more than 1 or 2 RT-PCR tests, the plaque assays were negative after 2 weeks. So, that's certainly not conclusion that we can all say for everyone, no one is infectious after 2 weeks. But it does suggest that people are RT-PCR positive and we can detect viral RNA, or at least portions of it, for many weeks in some people. And then others are only positive for a week. And plaque assay positive that week, and then plaque assay negative and RT-PCR negative. So there's definitely a huge amount of heterogeneity in how people clear the virus. And we did find that in people that, especially older than 60 years old, there seems to be a statistically increased chance that they're going to have lengthy RT-PCR positives. But again, even in those people, they were plaque assay negative after the 2-week period.
That's very interesting because that really jives with our experience. The dozen or so workers that continued to test positive during our 2-month or so period of test-based return to work strategy tended to be older, but I recall particularly one case who was definitely in the younger side, in the 30s. and for our healthcare workers, we actually asked them to be negative on 2 consecutive tests, at least 2 days apart, for a bit there. And that became really interesting and provided a lot of data that people probably didn't want to give us, but certainly showed that it's the heterogeneity, but also the longevity of viral fragments in secretions. And I guess the way I think about it is blood is a very homogeneous tissue, if you will, fluid tissue, whereas mucosal secretions are that spot only, and and it may or may not have that virus in it. So if you require only 1 test to return to be negative to return to work, there's 2, you might miss it, and then they come back. And interestingly, we had some people who thought, oh my gosh, I had another exposure, let me get retested, and they had already been released on the time-based criteria that we're now using, and then were positive again. So we adopted an approach to ask people in consultation with our infectious disease experts to ask people not to test the surveillance testing for 3 months, just because we don't have enough data to give a confident interpretation of that positive test. That said, our return to work program, we have a person, a provider designated to each positive case, to each index case, such that they can reach out, and if they have a relapse in symptoms, we can do a one-on-one consultation. I mean, I'm reveling in luxury here, and that we really do have a lot of support and making sure that we can contain rather than just mitigate risk to our workforce, recognizing that that's not something that everyone can do. Yeah.
And I think that's where those kind of concerning media, statements were like, can you get reinfected, 3 or 4 weeks after? I think they were exactly as you described, where people, got tested and they could test RT-PCR positive. They probably were continuously positive for many weeks. They just had an interval of time where they weren't tested, and they're not really reinfected. But, it's early data. There's so much that we still need to know. And so I don't know that we can make any hard conclusions, but that certainly is supportive, and I appreciate you sharing that.
And it's fascinating, let me tell you. We have a bunch of biosafety professionals on this webinar here who may or may not be doing contact tracing at work right now, or at schools, or helping people in their community who may not also have resources to public health. Maybe they're overloaded. Is there somewhere biosafety professionals can go to get additional information on how to contact trace? Open to anyone.
Oh, yeah. So for our contact tracers and case investigators, we do require them to go through the state of Colorado testing, or the contact tracing training. And so that's put on by the Rocky Mountain Center for, oh gosh, now I'm going to lose it. I had it and now it's gone. But it's the Rocky Mountain Center for, I'll have to get I'll provide the contact information. So it's a 4-hour class that is required, and it was the same class that was put on and provided to the state contact tracers. And so we require the same training, and then it's an hour-long, almost one-on-one training with an individual so that you can do contact tracing with a state epidemiologist and talk to them about what your process will be when you call these individuals. What if this person says this? How do I react to this? And so it's very helpful, and it provides a bunch of information. Johns Hopkins also has a really good training as well, which was provided early on and which a lot of us took. And then there's, it's Athos. Has another program that you can go on their website and get trained on.
Thank you so much. Thank you so much for joining us today for this webinar. It's been quite informational.